Okay, so we have a lot of wonderful questions that you guys have provided us. We have an excellent panel here. Since there's some new members of the panel, I'm gonna kind of give them a minute to kind of introduce themselves, and we'll just kind of start from the very end.
Hi, my name is Kelly Parsons. I'm a social worker at Sanders Brown Center on Aging. I also help a little bit in K&I with Sarah Hatch, and happy to be here. Thanks.
We know Elaine.
Good morning. My name is Dr. Richard King. Good microphone here. Good. So I am an associate professor of neurology, and I work with Dr. Jaika in the clinic. We're seeing people who have cognitive disorders. I'm also the site PI here for the Alzheimer's Disease Neuroimaging Initiative and co-director for the MD PhD program. So wear a lot of hats, and including the hat of being on call right now as we speak. And so if I happen to get a phone call and step out for a second, you'll understand why.
I'm Jordan Harp. I'm an assistant professor of neurology and a neuropsychologist. I work also in the clinical core of the ADRC. I work with Dr. Schmidt on the Alzheimer's and Down syndrome project as well.
Okay, so we had many questions, and we're going to address as many as we can. One of the first questions here that's really a good question is, how do I sign up for a clinical trial? And I will direct that to, let's go to Dr. Jaika.
So very important. I think the first thing to do is to talk with one of us, and there's an entire table out there, and we really brought only a small handful of the different things that we're doing today. There are several dozen studies actively ongoing to really address something for everyone, and that is our motto. Something for everyone, whether you're normal, whether you're impaired, whether you're severely impaired or mildly impaired, whether you have Lewy body disease or Alzheimer's or vascular disease, there's something for everyone. So please just contact us.
Can I also say we see more people with normal cognition than we do with memory and thinking problems. So just because you go to Sanders Brown doesn't mean you have something wrong. We're actually going to help.
Thank you. So the next question we have is for Dr. Tanzi. What diet is optimal to improve gut flora? And maybe you could comment on the ibuprofen a little bit.
Yes, I knew I was going to get that question. So the first thing and most important thing is talk to your physician. There's no one diet that's right for everyone. The studies that have been done suggest that diets that are high in sugar and highly processed foods are not as good for you. You want to eat things that make your digestive system work for it. So fiber and things that are not so processed. So processed food, not so bueno. And you want to make sure that whatever you're eating really sits well with you. So if you have any kind of, intolerance to gluten or anything else, you need to modify it that way. There have been some studies suggesting that a Mediterranean diet is a good thing. And of course, it's vegetables, and fiber and fruit and not a lot of sugar. The sugar is probably the worst thing, more than the fat. At least in our preclinical studies, it suggests that it's really the high fructose, and I don't mean bananas by that. I meant like, candy and things like that. That is very rapidly absorbed, and it really is one of the main triggers for inflammation. In terms of ibuprofen, I would say that it's a very, what we call a dirty COX cyclooxygenase inhibitor. So COX-1, COX-2 are the enzymes that it targets, and those two enzymes need to kind of be in balance. There were some drugs that were targeted more at one versus the other, and they were pulled from the market because they caused heart problems. So I would say that ibuprofen probably works because it turns down the volume on the system, but it's a very dirty drug, and a lot of people have intolerance to it, and they get, bleeds and ulcers. So definitely don't don't go out there and just consume large amounts of ibuprofen. It just tells us that by handling the inflammation, that your brain benefits somehow and your body does. The best anti-inflammatory is exercise, walking, 20 minutes every day, break a sweat. That's all you need to do. And it's different for everybody.
We often say that exercise is our best anti-aging formula on here.
Okay, next question. This is for Dr. Morgan. What are some of the side effects of the therapies that you noted, based like nausea, weight gain, sleep disturbances, based on, I guess, some of these vaccines that are coming out?
So in terms of the immunotherapy approaches, and Dr. Dyke should probably contribute to this as well, since he's the one treating the patients, not me. The major one is the ARIA. And it's largely again asymptomatic, as people don't know that they have it. But it puts them at an increased risk of further complications going along. There are one of the problems is the drugs have to be infused. So you have to sit in a chair for an hour or so, and you've got a needle in your arm. And putting anything into your body can cause local infections. You can have problems with that. Those are probably the major side effects that we're aware of. What we'll probably learn as we get more and more people from a broader part of the population. I mean, people in clinical trials, unfortunately, are a very select group. They often don't have any other comorbidities, that it's other diseases that the drugs might interact with. And so we're going to find those things out as we go along, and we start including a much broader swath of mankind and humankind into the pool of people who have been exposed. But there aren't a whole lot of major problems other than the ones that we've highlighted already.
So, I will comment on that and let everybody know as well, that, while many of the experimental medicines, and the reason why they're in experimental trials, the reason why there's frequently a placebo associated is so that we can understand those side effects. These anti-amyloid therapies, those that are currently approved, and those pending approval, like donanemab, which likely will get approval in January, that's my prediction, anyway, have been tested in thousands of people. So we have a pretty good idea what those side effects are. And as Dr. Morgan says, very few side effects outside of ARIA. The one thing that we do see is sometimes folks will have a local, and we do see not infrequently, maybe 1 out of every 20 patients will have a mild sensitivity reaction to the antibody. They can develop chills or a slight fever while they're receiving the infusion. We treat that not with ibuprofen. We treat that with a little bit of Tylenol and a touch of Benadryl. And that has never failed to completely resolve those symptoms for folks. So again, these medicines appear remarkably safe if we can avoid the ARIA.
Just a follow-up on that, Dr. Jaika, this is a very specific question. Does white matter lesions disqualify you from taking Leqembi? And if you take Leqembi, will that disqualify you for new studies?
So the answer is no and no. In a nutshell, I will say there's certain folks, really what we're looking at to exclude folks is evidence of significant prior bleeding in the brain, which is spontaneously a part of Alzheimer's disease. 1 out of every 10 Alzheimer patient or persons with amyloid in their brain will have spontaneous bleeds, but that risk goes up a little bit with these medications. If there's complete injury to the brain from white matter disease, then we would call into question whether or not you even have Alzheimer's disease. Maybe it's vascular dementia. Really important. And the field really is pivoting right now. And so I am already writing grants to add new medicines, like our medicine for late in TDP-43. Can I give that to folks who are also receiving Leqembi clinically to see if I can push the limits? And slow the disease, not by 30%, but maybe by 60%, make it more appropriate for those that are over the age of 80. These are active pursuits in the field.
And every clinical trial has their own set of inclusion and exclusion criteria, so it's hard to generalize across the board. But I think the field is definitely moving towards inclusion, like Leqembi and. There'll probably be a few studies for which if you're on Leqembi, you may not be eligible, but every study has its own set, and that's an important part that you're becoming educated about what you're eligible for, as I tell you.
There were some very specific, more personal type questions, and at least Dr. Harp said he would stick around at the end to answer those if people wanted to come up and ask those very specific personal questions. A more general question here is a question asking about the risk of Alzheimer's disease with family members. And so if your mother or father has Alzheimer's versus a cousin versus an aunt and uncle, Dr. Hart, maybe you would like to answer that question?
Doesn't come up. Okay. Yeah, so in some forms, and we covered this a little bit, specifically, Dr. Morgan covered it a little bit in one of his presentations, that we have those early onset forms that are related to very heritable genetic changes, but they are quite rare. And those are the kinds that you'll see in 40s and 50s, sometimes earlier. If you're seeing something typical later onset Alzheimer's disease, it's really more of a question of how many people you have in your direct ancestry. So 1 or 2 might raise your risk slightly. The closer they are, it's slightly more. So a mother, sure. If you have a history of along one of your bloodlines, as we might call it, many people developing even late onset Alzheimer's disease, then that does increase your risk even more. So in those cases, you want to just try to do as much preventive monitoring as you can. If you start to really notice changes cognitively, go see a memory disorders neurologist, and they may recommend that you come see someone like me to wear out your brain doing all these tests. But that there's a benefit to it, because if you know ahead of time that there are some changes, we do have symptomatic treatments, and now we have some disease modifying treatments that you might qualify for. If you find out that you don't have major issues compared to people your age, you have a baseline. So if you get worried later down the line, our tests work even better if we have something to compare it to from before.
Okay, next question is, how does hormone replacement therapy affect dementia process? Does it help? Is there any effect on that? Jordan, would you mind speaking on that?
I think I might want to refer that back to Dr. Jaisar.
Perhaps Dr. King would like to take on hormone therapy. Not take hormone therapy, but take on hormone
You
therapy.
never know after this question might need someone. Yeah, so it's been kind of a mixed bag. So when initially there was a big hope that hormone therapy was going to be kind of a cure-all, so look at people at menopause versus not, and there was a big longitudinal women's aging study, and the value of the hormones was kind of went up, and then it came back down, and they were saying that it doesn't help. For me, and this is probably going to vary a little bit from people's perspectives, I don't know that there's any one necessary answer on that. Is like, if you need symptomatic treatment because somebody is postmenopausal, then you're certainly treating that. And there are a number of factors like brittle bones and features that having the hormones on board can definitely help. I don't know of specific like hormonal therapy versus neurodegenerative results. I think it has more to do with treating your general health. And so I think if you need it, you should take it. Taking it just prophylactically without having an underlying need, I don't really have a lot of evidence for that. Anybody else has a different?
Like
opinion?
ibuprofen and perhaps Dr. Tansey, your work with gender related issues. I'm sure you have a lot of expertise.
Yeah, so I agree. There's a fair amount of controversy in the field and conflicting studies. The timing may seem important. But I think it's still an unsettled question. I agree with Dr. King that if you need it to treat other conditions, by all means do it. But there's no evidence that, you know, getting it is going to significantly lower your risks for dementia.
The next question, we had several questions about ApoE and genetics. So the questions are for example, how can I get tested for ApoE? And if I'm in a trial, do I get APO results? Do I get my lab results? What information will I obtain when I'm in a trial? Dr. Jaika, maybe?
So I'll just quickly say, that most trials do test for ApoE genetics. Not all studies allow us to disclose those results, but that is changing. There's a huge push that you really should have access to all your information. And now ApoE genetics are actually recommended by the FDA if folks are going to come in and receive Leqembi therapy. So I think, right now, clinically, you can get them tested. It's a very simple test to order in office, and we're doing that for our folks that are eligible for Leqembi. Research-wise, we're really pushing to be able to disclose, and we do disclose in many, many studies what your risk is. But remember, ApoE is not an absolute, right? It alters your risk, but you can have ApoE4 and never get Alzheimer's, or you can have no ApoE4s and still get Alzheimer's.
I just wanted to add to that. And I'm not a part of 23andMe. I don't make any money or anything like that on it. I can tell you that they have significant database information that does tell you the relative risk and if you have any alleles for the neurodegenerative diseases. Again, a lot of these are not fully penetrant, so it doesn't mean you're going to get the disease, but it does give you like a big picture, like your dance card of genetics, right? And what you have. So that's a possibility. They always offer a discount during the holidays. I'm not sure why. But, I think personally, knowledge is power. What you do with that knowledge is entirely up to you. But now that we actually do have disease modifying therapies for the first time, I think that's great, because then you could consider getting a baseline. If you have genetic factors that predispose you, if you have a family history, you begin to assemble the picture for yourself. And that may be something that you want to do, but it's not for everybody. Sometimes, kids don't want to get tested, or they don't want to know what their parents have because they don't want to know what they have. And you have to respect that. But I think you could do that if you wanted to through some of those services. They're also going to start collecting stool because the 23andMe are going to get into the microbiome arena.
And just in regards to dance cards, I just want you all to make sure you know who you're giving your dance card to. With these companies, you don't know if they're going to be sold, you don't know if they're going to be bought, things like that. Just other things to consider when you're looking at finding out what your genetic makeup is.
Yeah, you have protections when you're seeing a physician in the clinic. You don't necessarily have those protections in a third party.
I think there's another thing to consider going forward, however, and that is blood tests. We're very, very close to having some meaningful ways to evaluate your risk outside of genetics with a simple blood test. And that's going to happen in the next year or so. And so if you did have that concern, you could find out if you were at risk. And if you were, and this will also add to your risk, and probably more so than just your genetics, is knowing that, I'm getting phosphorylated tau in my blood. That means maybe I'm going to start having cognitive decline soon. I'd better go see Dr. Jaika about a clinical trial to prevent it from happening. So those are the sorts of things you're going to see in the near future.
And I think we as people, as humans, have a hard time actually interpreting what risk means. Like, what was the most risky thing that I did today? It's probably driving here. Yeah. Yeah, this is much more so. And so it's important to have context when you're doing these tests, because they're gonna say, oh, your risk is increased by 27.4. What does that actually mean? Yeah, so it's hard to interpret by itself, so helps to have context.
That's true. And I just wanted to say, a plug, 23andMe, give the gift of disease this Christmas.
Genetic dance card.
So this will be a quick follow-up. We pulled it up in the list. And so if I participate in a clinical trial, how widely will these findings be shared? And follow up there, would findings cause doctors do not cover me if a condition is found that was unexpected?
I'll say two things about that. The first is, when you're in a clinical trial, typically, especially if it's, conducted at our center or funded by NIH, trial results and data is protected by a federal certificate of confidentiality that can only be broken by the United States Supreme Court. The big one. So really, really important. Names and identifying information are never shared with the sponsors. That is kept top secret. But then we really do want and have an imperative to share the data once your name and identifying information is removed, so that we can maximize the research that we're doing. There may be an investigator, I don't know, up in northern Canada who's whipping something up in the cabin, that could advance the disease. We want them to have access to the data, no matter where they are, and really be impactful.
So another question that we have, we're talking a lot about inflammation. So a natural question is, would corticosteroid therapy like prednisolone be beneficial?
Great question. The short answer is no, because it immunosuppresses you, right? And you don't want to be immunosuppressed. Aging is already involving a fair amount of immune dysfunction. And while the epidemiological literature does associate, in some instances, use of corticosteroids with decreases in many neurological diseases like Alzheimer's, other dementias, it's definitely not recommended, because it will immunosuppress you. And then you'll have all sorts of other issues with, the next pandemic and whatever else comes out your way.
Yeah, the steroids are really helpful if you have an immune system that's like acutely out of control, like the patients I'm seeing in the hospital today. There are a number of them that have like optic neuritis, but it's inflammation around their eyes, and we use the steroids in that context to turn that down. The long-term effects of steroids are actually very difficult to manage. You get bone brittles, you get diabetes. There's a number of side effects, and so we're always like, what's the benefit? What's the side effects? Do the benefits outweigh side effects? And in the long term, that's almost always negative, unless you have a specific reason for using it.
There's been clinical trials done with steroids that found no benefit in Alzheimer's, and in the animal studies, we can actually show the generation of a part of the brain called the hippocampus, which is critical for learning and memory, with high doses of corticosteroids for long periods of time. So the answer is clearly that's not the answer.
This is a question probably directed towards Kelly. And so the question is, who will help me navigate this process of moving through, especially once somebody in my family has a diagnosis?
So once you have a dementia diagnosis, what you're going to ask is what type of dementia that is to your PCP. You also want to then get a referral to a memory clinic like KNI, UK Healthcare, and find out what exactly type of dementia you have. Once you get connected in, then you'll be referred to somebody like me or Sarah, or Regina Goodman, who works in the area on aging at the Bluegrass Ad, or Alzheimer's Association. We have Erin Gillespie. So there's a lot of professionals within this community that will pull around you and make sure you are educated on the disease. You're educated on what you need to do because of the diagnosis, like get an advance directive, make sure you have a power of attorney. Those different things, they're very, very important. Even if you don't have the disease, I strongly encourage you to get one if you don't. And then we really talk about, how are you doing? How is your loved one with dementia doing? Are there any behaviors? We have family caregiver workshops that are quarterly for anybody and everybody. That's both in person and online, which is exciting to help walk you through. Because if you know someone with dementia, you know one person, right? Everybody's experience with dementia is going to be different. And we see everybody's experience, which means we might have an idea if you can't see the bathroom or the bathtub and you don't want to get in it because it's white and the wall's white. Well, maybe if you just put some stickers up or those, like vinyl stick things so that your loved one can see the difference between the wall and the bathtub, and then they'll be able to get in. So that's the kind of stuff that Sarah and I do at Sanders Brown. And that's what would happen if a loved one has dementia. We would make sure you are tuned into the family caregiver national program where you get about $300 a year for anything you need, like chucks or a walker if Medicaid's already paid for one and you need another one. You also get about $2,000 in respite care. They can find somebody for you, or you can have a family member do it if you'd like. Again, that's the National Family Caregiver Program. Our social work table is right there, and we have lots of resources for you. I'm happy to meet, and our cards are out there as well.
So this is a question from our online viewers. What is the impact of therapies like IVIG that have now expanded to chronic immune conditions? And does B cell and T cell products from the IVIG cross the blood-brain barrier? So if anybody, Dr. Morgan, has any experience on IVIG?
So I at one point consulted on trials for intravenous immunoglobulin, and they essentially don't work. They did not show long-term benefits. The general idea was that some people are making spontaneously antibodies against the A beta amyloid peptide, and that those antibodies would be present in an IVIG preparation, and therefore that would be as protective as getting the doses of the monoclonal antibodies, but from a different source. But the trials just simply did not succeed in showing any kind of benefit. The rationale for it probably was inadequate. We now know that the dose of the antibody needs to be pretty high in order to be effective. Antibodies, very little gets into the brain. Less than 0.1% of the antibody in your blood is present in your cerebrospinal fluid. And so one of the key features of these second generation antibodies, I didn't talk about this, but the amyloid appears both as individual peptides, but then aggregates into what we call fibrils. Sometimes we call them oligomers, which means they're stuck together. The antibodies, we think that the oligomers and the fibrils are really what is causing the problem. The single cell, the monomer peptides are probably not, but there's a lot of them there. The new antibodies have a unique property compared to the first generation antibodies in that they don't bind the monomers. They only bind the aggregated forms. And so the little bit that gets into the brain doesn't get sopped up by the monomer. And it now has enough of it to get at the oligomeric forms and the fibrillar forms of the amyloid. And so this is really why they're much more effective than those ones I showed you that failed, because there's enough of it there to actually have an effect.
Yeah, I will say we did that failed IVIG trial. Failed steroid trial. I'm an expert in failing.
Let's see. So there's a question about aphasia and other studies on this disease. I guess we'll make that more expansive and say, so is neurology here in general doing clinical trials in other areas then?
Yeah, and the answer is yes. There are active clinical trials in the area of Parkinson's disease, ALS, multiple sclerosis, seizure disorders, headache treatments. Really, neuroscience is the final frontier, in my opinion. And that's really where the explosion in new medicines is occurring. We need to defeat these diseases. Because our nervous systems are important.
there's always a ton of stroke trials as well. Those things are ever present.
So I think we're running short on time. We got to as many questions as we could. If you have a more specific personal question, maybe some of our panelists could stick around for a little bit and answer those. We want to again, thank you. And I think Linda wants to say a few words as well. Thank you very much.
I don't really have too much to say other than just to thank you all for coming. It's been a great event again this year. And please, please, please turn in your yellow evaluation sheets. And thank you all. Have a great weekend.